Welcome and thank you for joining us for today's symposium, Emerging Topics in Women's Health, a focus on uterine health, as part of VCU's Health of Women 2023 conference. I am Irina Ninye, Chief Science Officer of the Society for Women's Health Research. SWHR is a thought leader in promoting research on biological sex differences and disease and improving women's health through science, policy, and education. For more than 30 years, SWHR has led interdisciplinary groups of researchers, healthcare providers, patient advocates, and policy leaders to address diseases and conditions that disproportionately, differently, or exclusively affect women. SWHR's work in the uterine health space has been leveraged to inform disease prevention and treatment and to provide guidance for research, clinical trials, and effective policy solutions. Today's symposium will discuss advancements in research in women's healthcare with special emphasis on uterine health conditions. Our distinguished panelists will present strategies as to how research, clinical, and policy stakeholders can all work together to address persistent gaps, disparities, and unmet needs in uterine health. We will be live tweeting during the event and invite you to use the hashtags #SWHR Talks Fibroids and #SWHR Talks Endometriosis on social media. Endometriosis is a chronic gynecological disease that affects approximately 1 in 10 women of reproductive age. Key symptoms include severe pelvic pain, infertility, fatigue, and abnormal menstruation, all of which can significantly affect an individual's mental and physical health, including interactions with their family, friends, and healthcare providers. Stigma associated with endometriosis has been understudied and is rarely discussed in current literature, yet can contribute to diagnostic delays experienced by women living with endometriosis. Dr. Jhumka Gupta is an associate professor in the Department of Global and Community Health at George Mason University. Her research program applies a social epidemiology framework towards investigating the mental and reproductive health implications of gender-based violence against women and girls, with a primary focus on addressing challenges faced by vulnerable populations of women, both within and outside the US. Dr. Gupta has even applied this social epidemiology lens to examine stigma and perceptions of endometriosis, which she will talk about today. Over 70% of women are estimated to develop uterine fibroids or leiomyomas by age of 50, and approximately 25% of women with uterine fibroids will experience symptoms severe enough to require treatment. Attempts to better understand the factors that influence prevalence and disparities associated with these non-cancerous but serious growths have been made. However, significant knowledge gaps continue to persist, which hinder care for individuals living with fibroids. Improvements in pelvic imaging and to diagnose and assess fibroids, elucidating the factors that contribute to these disease disparities, especially among women of color, and developing more fertility-friendly treatment options would provide great steps to reducing the deleterious effects on the health and quality of life for millions of women. Dr. Ayman Al-Hendi is a professor and gynecologist at the University of Chicago who specializes in comprehensive women's health with expertise in minimally invasive gynecologic endoscopy. His skills in hysteroscopy and laparoscopy allow him to diagnose and treat polyps, fibroids, and bleeding disorders with reduced scarring, pain, and recovery time. As a physician scientist, Dr. Al-Hendi is also dedicated to using basic and translational research to better understand the cause of gynecologic conditions and investigate new treatments that offer improved outcomes and overall quality of life. The heavy bleeding, clotting, severe pain, and other issues associated with symptomatic fibroids not only impact a woman's physical health, but can also affect her sexual and mental health. Managing disease symptoms, excessive costs of feminine products and medications, and mood instability can evoke feelings of embarrassment and shame for individuals living with fibroids. Moreover, the social and cultural constructs that normalize gynecologic-associated pain can further complicate the process of seeking treatment and a woman's ability to maintain a suitable work-life health balance. Tanika Gray-Valbrun is a journalist and educator with a passion for women's health. After her personal struggles with uterine fibroids, Tanika was inspired to form the White Dress Project, a nonprofit organization dedicated to bringing awareness, raising funds, and increasing education about the uterine fibroid epidemic. In addition to encouraging women to be their own health advocates, Tanika works as a content producer for CNN, where she has been awarded 3 coveted Peabody Awards for her contributions in journalism. Tanika will share insight from her personal uterine health journey and how its impacts extend beyond gynecologic and into whole person health. Policy solutions that will properly address the unmet needs in uterine health research and care require engagement of both science and policy minds. The roles of researchers, clinicians, and patients in providing key perspectives in the development of healthcare policy agendas is critical to advancing women's health and promoting legislative change in the uterine health space. However, many are unaware of the often simple and practical opportunities to enhance their bench and bedside work through advocacy efforts. Lindsay Horan is a Chief Advocacy Officer at the Society for Women's Health Research, where she drives SWHR's policy agenda, building relationships with policymakers and key stakeholders to advance women's health. Lindsay leads efforts to raise the visibility and promote the value of health services and systems research through government relations, communications, and advocacy. Among her many areas of focus are building and leading coalitions and partnerships to advance healthcare policy legislation for endometriosis, uterine fibroids, and other under-recognized areas of women's health. After our 4 presentations today, live attendees will have the opportunity to engage in Q&A with a panel to discuss approaches to improve uterine health outcomes for women across the lifespan. So let's jump right in and begin with Dr. Junka Gupta to talk about addressing gaps in endometriosis research and care. Thank you for joining us, Dr. Gupta.
Hello, everyone. I'm excited to start off with the presentation side, and thank you for SWHR and VCU for putting this together. So when it comes to gaps in endometriosis care, I'm really going to hone in on what we talk about in terms of barriers to care for endometriosis patients, stigma and social determinants of health. And I'll point out that while we talk about it, the research, as Dr. Anina mentioned on this topic, is lacking. And I will point out some of the research that has been conducted to date. So before I begin, I just want to say that I don't have any financial disclosures to declare, and I wanted to acknowledge some of the funders of the data that I'll be presenting today, including the U.S. Department of Health and Human Services Office on Women's Health. So when we talk about social determinants of health, it's something that is discussed very broadly, but for the purpose of today, I'll go with the Robert Wood Johnson Foundation for Health's definition of the idea that health happens where we live, learn, work, and play, and not necessarily restricted to a clinician's office or in the pharmacy. And social determinants of health are very much symptoms of broader systemic inequities in society, whether it's discrimination, gender bias, those types of things. So when it comes to endometriosis, there's systematic inequities that prevent help seeking and receiving help and treatment. And they can impact social, economic, and educational functioning. So just based on this, what I really want to point out is that an endometriosis patient needs to interact with their world, whether it's at school, university, the workplace, family, friends. So if there's stigma or those types of things happening in those arenas, that is going to impact the type of care that's accessed and potentially treatment as well as mental health. And we'll talk about that more. So stigma is something that we talk about a lot with endometriosis, that, menstruation is stigmatized, pain is stigmatized, people aren't talking about it because of stigma. But what I find interesting is, although we talk about stigma quite a bit, when it comes to actual research and public health interventions to address stigma, what we see that has happened or is happening is far less compared to what is acknowledged in conversations around what is a very important and critical barrier influencing endometriosis patients' lives. So stigma is indeed a social determinant of health, and I am big on definitions. So stigma can mean very different things to people, but I like to use the definitions by Drs. Phelan and Link, in that stigma is a social process that results in the devaluation and discrediting of people with various characteristics, attributes, and or identities. Even further than that is stigma is an exercise of power to simultaneously label, stereotype, and cause separation, discrimination, and loss of status in the lives of others. So what we can see from that is, discrimination against people with chronic pain, with invisible illnesses, with menstrual related pain. Those are really important facets when it comes to stigma and endometriosis. I shared this because I wanted to show you just exactly where we are in terms of the research literature on endometriosis and stigma. And you can see in the blue line, since 1980, there have been 27 articles total published in the literature that have stigma and endometriosis in them. And when you compare that to, say, HIV, you'll see about 7,500 articles since 1980. And they don't look that different because the scales are so different. We're talking 27 versus 7,500. But I say that because HIV is very stigmatized. And we've also, as a field, have acknowledged that in order to improve clinical and population health outcomes, it's insufficient to just address at the individual level clinical care, but we also need to address these broader societal conditions such as stigma. That's what we hope for endometriosis as well. So stigma can, show up at different levels. At the structural level, just a lack of funding for research and public health programming when it comes to endometriosis, lack of emphasis in health profession and public health curricula. There are the individual perceivers, and these are the people who are doing the stigma, so minimizing pain in healthcare settings, accusations of over-exaggerating in various places, family, social, work, academic. And then there's the targets of stigma. And what can happen is, these women can discontinue seeking help, socially isolate, and or grow vulnerable to health misinformation, which is also really important as well. So people with chronic illness are stigmatized because they're perceived as poor exchange partners, meaning they may be perceived as needing more than the relationship will allow, and often can be seen as a threat to others, such as, infectiousness in some cases, or just taking away resources from others as well. We know that there are very critical health impacts of stigma, including poor mental health and social isolation, distrust, and just an overall lower quality of life. For endometriosis, as I mentioned, it can also prevent help seeking, prevents the receipt of social support, which is also critical for mental health and driving social isolation. We talk about anticipated stigma. There's different forms of anticipated stigma. For today, I'm going to focus on this type. And that's when you're really concerned about what can happen in the future, usually because you've experienced stigma in the past. So worrying about being treated unjustly, worrying about denied opportunities, worrying about being dismissed. And these are really important for life course considerations. If we're talking about younger women and menstruators, if they're experiencing this, in adolescence, when symptoms often begin, it's a whole lifetime of experiencing this type of fight or flight stigma. There's also concealable stigma considerations to consider in that it's not easily visible to others. So there's this threat of discovery and disruption. So when you're having symptoms, it may disrupt various aspects of life. So there's also this added layer of a fear of being uncovered by others. This is just a conceptual model that our team developed on looking at endometriosis symptoms, disruption, and mental health. And it's just the idea that symptoms can lead to disruptions in various arenas. And due to lack of understanding of endometriosis, societal gender bias, and lack of social support, they can experience stigma from various actors, and that can create distress and toxic stress and social isolation, which can translate into poor health outcomes. In our study that we did recently with undergraduate students, we wanted to look at what is the frequency of disruptions in various dimensions due to symptoms suggestive of endometriosis. This population is underrepresented in endometriosis research. And what is association between disruptions and anticipated stigma? So it was an online anonymous survey, and we explicitly asked about symptoms associated with endometriosis. This age may not necessarily have an official diagnosis, so we did not ask. It was not based on that, as well as explicit discussion questions around stigma and disruptions. So this is just some examples of the different types of disruptions that we assessed. We wanted to look at things that were important to this population: academic, social, and family, as well as work-related. We used the anticipated stigma scale, which is the chronic illness anticipated scale that was developed by Dr. Valerie Earnshaw. And it really assesses respondents' perceived likelihood of experiencing negative behaviors from friends, family, professors, employers, and others. Will they blame you for not getting better? They will not think highly of you. They'll not at work. They will not think you're capable of fulfilling your responsibilities. Or will a healthcare worker think you are a bad patient? And there's more items. These are just some examples. So some of the key findings, these are our respondents. So our analytic sample was 468. One thing I did want to point out is that unlike a lot of endometriosis research, we did have considerable respondents who were Black respondents as well as others of color. So when we looked at the past year disruptions due to symptoms, there were high levels of those who reported symptoms of disruptions in various spheres, most commonly social, followed by academic, and then work. So this is just to show how the mean anticipated score varied by some key demographics. And when we looked at race and ethnicity, Black and Latina respondents reported higher mean anticipated stigma than white respondents. Those who were bisexual or otherwise not reporting straight had higher mean anticipated scores. Those born outside of the US had higher mean anticipated scores. And then in terms of enrollment status, part-time students reported higher mean anticipated scores than full-time. And then the question is, were disruptions associated with higher anticipated stigma scores? And these are just, some comparators. When you look at any disruptions, it was a mean score of 2.1 versus 1.43 for no disruptions. School disruptions, a similar pattern, higher mean scores among those who reported school disruptions versus none. Similar pattern for social, it's all consistent here. And then finally, work. And then what we wanted to look at is, we saw in the unadjusted analyses that there was higher anticipated stigma scores in those reporting disruptions compared to those not. But then what we wanted to do was see, okay, so what is driving this? And is it the symptoms or is it the disruption? And our main question was regarding the disruption. So in model 3, when we adjusted for demographics and symptoms, these disruptions were still significantly associated with higher anticipated stigma scores. So some of the key takeaways were that there were higher levels of disruption due to symptoms that were suggestive of endometriosis, spanning multiple domains of life, work, academic, social. And the anticipated stigma mean scores that we saw, they were actually broadly consistent with what the research has found in other chronic illnesses, such as HIV, substance use, mental health. The difference is we just don't have similar levels of funding for endometriosis. And also importantly, disruptions were associated with higher anticipated stigma scores even after accounting for symptoms. And this is important because, yes, we do need to address the clinical aspects of the disease, but the fact that disruptions were also associated with higher mean anticipated scores really speaks to the need for more public health and social interventions to make the social climate more friendly for patients with endometriosis and really addressing stigma. So there were limitations. It was not a probability-based sample, as I mentioned, not a confirmed surgical diagnosis that just wouldn't be that common in this age group anyway. And these measures need to be validated with the sample and condition. The implications, though, are there are some life course and intersectional implications. So we did see higher mean scores of stigma among Black, Latina, immigrant, and sexual gender minority women, and those point to larger structural inequalities. These are very consistent with what we see in the broader health equity literature. Future research may seek to examine weathering as it pertains to endometriosis and other gynecological disorders. And what I mean by that is what I alluded to earlier, just a lifetime of just this toxic stress due to this type of stigma without the support. This is just to highlight that all of these stigmas, they do intersect with larger societal inequities. And implications for public health and clinical practice is that, there's really a need to address stigma at multiple levels in terms of policy, funding, addressing anti-discrimination. One area might be implicit bias training among healthcare providers and engaged stakeholders outside of the healthcare setting, such as teachers, club leaders, peers, family, employers, especially when we're talking about these age group. We need support with symptoms and navigational challenges. And what I mean by that is patient navigators. That's a really excellent model for care for patients with breast cancer and other types of health conditions. And perhaps that's something that we need to look at for endometriosis. And lastly, we need from the public health end some norms change and anti-stigma interventions. And that's a project through Office on Women's Health that we're starting to develop and test in our team. So that wraps up my presentation, and I just really look forward to the discussion.
Thank you very much, Dr. Gupta, for your presentation. Next, I'll invite Dr. Alhende, who will discuss disparities in uterine fibroids.
All right. Thank you so much, Irene. I would like to thank the SWHR for the kind invitation and really congratulate them and thank them for all the outstanding work, advocacy they do for women health research. So I'm going to share my slides. Okay, you can see my slides, okay?
Yes.
Okay, perfect. So the title of my talk, as you heard, is Eliminating Health Disparity in Uterine Fibroids. So my hope in the next 15 minutes or so is to cover some of that. And of course, what we cannot cover in the 15 minutes, I'm happy to entertain questions as well. These are my disclosures. I would like particularly thank NIH for their support of our work for the last 20 years or so. So the objective in the next 15 minutes or so, I'm going to touch briefly on uterine fibroids, biology, diagnosis, and treatment. But really, most of the talk will be why are uterine fibroids more common in women of color? And of course, hand in hand with that, we'll touch on the health disparity angle and maybe how can we start to think about eliminating this health disparity. Then I'll end by some of the really interesting translational work we do in our team and actually clinically on the secondary prevention of uterine fibroid, which we are doing now and we've been doing for years actually. But then the innovative approach of primary prevention of uterine fibroids, which is still in the research process and not in the clinical reality yet. So just some basic background on uterine fibroids. I think for this audience, you all know uterine fibroids. The other name is leiomyoma. Leo means uterus in Latin. Myo means tumor, means muscle really, and oma means tumor. So it's really a tumor of the muscle layer of the uterus. And that's exactly what uterine fibroids are. So they start from the wall of the uterus, which is muscle. And these are benign tumor, not cancer, nothing to do with cancer. And there's a lot of variability in the disease. Some women have a single tumor, a single lesion. Some can have up to 70 or 80. The largest in a myomectomy I've ever done, we removed more than 70 fibroids from a single uterus. And also the size of these tumors can vary from this very small, tiny, half a centimeter size to really some of my patients say a basketball size fibroids. So fibroids are really a major cause of morbidity and low quality of life in women, unfortunately. They can cause symptoms such as heavy menstrual bleeding or regular menstrual bleeding. And of course, if that goes uncorrected, it can lead to anemia, fatigue, chronic fatigue, and a lot of other symptoms. I have patients tell me, students who cannot function well in exam while used to be much better, or a new employee who are about the risk to lose their job because they are being accused of being lazy because she's just tired all the time. I had some of my patients actually sleep in the waiting room while waiting for their appointment because they are just tired because of the anemia. Fibroid also can cause pelvic pressure, pressure on the bladder, urinary symptoms, bowel symptoms, what collectively can be called bulk symptoms. Also, fibroid have been connected to infertility, and when the individual gets pregnant, women with fibroid have higher risk of recurrent miscarriage and postpartum hemorrhage, bleeding after birth, and also delivering early, preterm labor. So as you can imagine, when you put this all together, fibroids is a major cause of low quality of life in patients who are suffering from this very common disease. Unfortunately, this disease is also a major health disparity. It's about 4 times more common in African American or Black women compared to European American or white women. And also Hispanic American women have about 2 to 2.5 times more risk compared to European Americans. So it's a major health disparity challenge, and we'll touch a little bit about that in a second. Why is that? Fibroids love the hormones that comes from the ovary, estrogen and progesterone. So estrogen and progesterone actually work hand in hand to enhance the growth of fibroid. And as I said, there's a wide range of the disease from few millimeters to many, many centimeters. This is kind of the state of the art now where we think fibroid come from. They come from an abnormal stem cell. The stem cell is the origin cell in the wall of the uterus. It's supposed to just produce a nice, healthy wall of the uterus, myometrium. But if this cell become abnormal, then these cells then start to grow and produce a lot of other cells, which eventually make those fibroid tumors. Fibroid also is the #1 cause or indication for hysterectomy, which is, of course, the removal of the uterus in the US. And in the US, particularly, we do too many hysterectomies, in my opinion. We do about 600,000 hysterectomies every year. Many of those is because of fibroid. We are by far the #1 country among developed countries in the number of hysterectomy we do in our patient. We do about 6 hysterectomies per 1,000 reproductive age women. The next country after us is Germany, and that's already half of that. Canada do only about 1.2 hysterectomies per 1,000 women, which is probably around the correct ratio. So how do we treat fibroids? Still, unfortunately, the mainstay is surgery, typically in the form of hysterectomy. Myomectomy is when we remove the fibroids, but then suture the uterus back together to keep the uterus in. Usually we do this in women who wants to still have future pregnancy. We do about 30,000 myomectomies per year in the US. And there's some other techniques, but they are used much less. There's some also radiological techniques such as uterine artery embolization or focused ultrasound, but they are also not used quite frequently. But the exciting news, there is some actually a new FDA approved medical therapy for fibroid, something you can just simply take by mouth, and it actually will help decrease your heavy menstrual bleeding associated with fibroids. There are two options now in the US have been approved by the FDA. And I hope and believe that generally the trend will be towards medical therapy because many women are interested in avoiding surgery if possible. And why hysterectomy is not necessarily or shouldn't be the number one choice for this condition is because hysterectomy comes with potential negative effect on women's health. We are all familiar, like any major surgery, there's something that can go wrong in the operating room. So there's the short-term complication. And then we also know for many years about the intermediate complications of hysterectomy, something that can happen in the next 2-3 years or so, such as urinary incontinence, the prolapse of the remaining part of the top of the vagina called vault prolapse, and other consequences. But what's really important in the last few years, there has been more recognition of the long-term negative impact of hysterectomy, things that can happen after 15, 20, 25 years. This is a review article from Dr. Laveau in our team here at the University of Chicago, published 2 years ago, looking at that. And studies when we compare women who had hysterectomies in their 30s and 40s versus matched individuals who did not have hysterectomy, but matched in everything else. And even without removing the ovary, and then we look 20, 30 years later, those who had hysterectomies had increased risk of hypertension, diabetes, cardiac issues, coronary artery disease, and on that slide, I didn't include that, but also increased risk of dementia. So some serious long-term complications have been now connected to hysterectomies. And the ACOG, the American College of Obstetrician Gynecologists, now in their most recent guidelines released in June 2021, suggest that when you sit down and counsel your patient about hysterectomy, you should also discuss the long-term negative impact of this procedure. Well, if we're not going to do surgery, then we need effective evidence-based medical therapy. And this is a kind of a comprehensive list of the different medical treatment options available for fibroid. I like to divide them by hormonal versus non-hormonal. Obviously, because of the time limits, I'm not going to be able to go through all of that. But like I said, there are two FDA-approved recent medications here in the US, urologolics and elagolics for treatment of fibroid. Also, our team and others have been really pioneers in developing non-hormonal, natural product treatment of fibroid, things like green tea extract, EGCG, epigallocatechin gallate, and also high-dose vitamin D. And there's some our publication on this. I would encourage you to go there for more details. Beside the immediate and the direct health impact of fibroid on the individual, there is the overall impact of fibroid and the cost of treating fibroid on the society. Fibroids, if you look at the cost related to the diagnosis, the treatment, but also the impact the heavy bleeding, the anemia have in work productivity, obstetrical complications, that has really a major economic impact on the healthcare system. This is a work from Dr. Jim Seegers at Hopkins, estimating the cost annually, just in 1 year, in the US alone, about $34 billion. So there is a major quality of life, health impact on the patient, but there's an overall impact on the society and the healthcare system as well. This is from a review article Dr. Yang and our team published last year, summarizing the risk factors or the state-of-the-art understanding why fibroids is more common in women of color, and what are the risk factors for fibroid in general. So things like environmental pollution and exposure to these harmful chemicals, collectively called endocrine disrupting chemicals, things like phthalate, etc., that are found in many cosmetic products and in certain food, especially preserved food products and so on. Exposure to this EDC, especially if this happened early in life, when the uterus is still in the development stage, increased risk of developing fibroid later on in life. Obesity also has been connected to increased risk of fibroid. Vitamin D deficiency, we were pioneers in publishing on this in 2010, so about 13 years ago now. And since then, more than 100 papers came to the literature confirming our finding that vitamin D deficiency is a risk factor for developing fibroid. Altered bacteria, altered microbiome, not just in the vaginal area, but not just in the gut area, but also in the vaginal area and actually inside the uterus itself, can be also connected to fibroid. But I would say most important is this factor: racism, discrimination, and chronic stress. There's high quality literature connecting this to increased risk of uterine fibroid. And the interesting thing about this is additional literature and discussion suggested that actually racism and discrimination is not just a single factor, it's actually the underlying factor connected to all of this. Racism and the economic gap is probably why certain community, especially minority community, ends up living in some neighborhood where there's more exposure to EDCs and environmental pollution. Racism and economic gap also is why minority communities might not have easy access to fresh food and vegetables, which can then eventually lead to obesity. Now, obesity actually can lead to vitamin D deficiency because vitamin D is a fat-soluble vitamin. So when you are obese, you tend to be also vitamin D deficient. So you don't have to have all of these factors, but one or more of these factors eventually lead to chronic inflammation in the wall of the uterus, in the myometrium. And this chronic inflammation can go for years, during teen years and early 20s and so on. And if that doesn't get corrected, or this risk factor doesn't get reversed, then this chronic inflammation eventually lead to DNA damage and the appearance of a mutation or some abnormality in the DNA. The most common one is the MYT12 mutation. And once you have this MYT12 mutation, then you're definitely going to develop fibroid. So because of this underlying causes, I call this slide about the causing of fibroid. Injustice caused it, but I think science can actually help eradicate it, and I'll touch on that in a minute. But this slide starts to give you some understanding why fibroids are so much common in women of color, as I mentioned earlier. And if you really elaborate more on the racism and discrimination and so on, you see this direct connection to health disparity. And it's really just the tip of the iceberg. This kind of start to engage into the underlying causes of, the economic gap and the discrimination, which, as I mentioned in the previous slide, all interconnect with these other biological risk factors, such as obesity, vitamin D deficiency, poor neighborhood, bad housing, etc., environmental pollution, and really all interact to biologically to increase the risk of chronic inflammation in the uterus, and that eventually lead to uterine fibroids. This is from really interesting work we are preparing for publication now. Dr. Bariani and the team, again, trying to dig deeper into the biology, why fibroids are more common in women of color. We talked about the social determinant and the social factors, but we also wanted to see how this interplay with the biology. And it turned out that Black individuals tends to have a bit stiffer wall of the uterus. Their muscle layer has more what they call extracellular matrix, more collagen and more fibronectin. Just physiologically, it's healthy, it's normal. But then this put them already at some increased risk but that's not enough by itself to cause fibroid. And then you get those other factors that I'm talking about: the poor housing, the eating unhealthy food, the obesity, the environmental pollution, which, as I mentioned, all connect to racism and discrimination. Then the wall of the uterus become even stiffer. And then again, if all of this doesn't get corrected, inflammation sits in. And once you have chronic inflammation for several years, then it's just a matter of time you will develop fibroid. And we think that's why, because of this consequence of events, that's why, unfortunately, women of color tends to have fibroid much earlier. I have seen Black teens when they're 19 years old and already with fibroid, and also tends to be larger and tends to be multiple instead of having a single fibroid. Interestingly, when we study tissues from European American or white women, it's exactly the same process, but because every single step is less common. You're starting with a softer myometrium, they are less likely to be exposed to these social factors, then they do develop fibroid, but much less frequent, and also tends to happen much later in life and tends to be smaller and less in number as well. So, of course, to address this underlying health disparity at the bigger picture is a major geopolitical, economic, and social process, which might take a long time. But in the lab, we wanted to take advantage of our understanding of the biology of the risk for fibroid, how fibroid develop early, to at least start to develop some simple ways to help women now, not in the distant future. So we developed the concept of secondary prevention, and secondary prevention means that the disease is already there, but it's early. And can we do something to prevent it from keep getting worse, from progressing? So, for example, many times we find women with just a single fibroid or a couple of small fibroids, maybe her menstrual period just starting to be abnormal, but the disease is very mild still. At the moment, unfortunately, the way we handle this is to say, well, you know, you don't seem to have a lot of symptoms, and the fibroids are still small. Let's just follow, maybe do an ultrasound every year and so on. And we literally, what they call watchful observation. And we literally wait until the disease gets much, much worse. Then we start to intervene with surgeries and invasive procedure. Our research suggests that using these very simple natural products, vitamin D, 5,000 international units per day, and this specific green tea extract, EGCG, 800 milligrams per day. These are over-the-counter products. You don't need a prescription for that. Although, of course, I would encourage our viewers, if they have the disease, to consult and to always discuss any medical-related issue with their healthcare provider. Using these natural products daily, based on our research, which have been confirmed by many other publications, can actually keep the disease under control and prevent it from progressing to this highly advanced status that need actually surgery and major invasive procedure. Also, this is a good approach if you end up having to have surgery, like myomectomy. We know the recurrence of fibroid is very high after myomectomy, about 70% in the following 3 years. Then you can also use this simple approach to at least delay or maybe prevent recurrence altogether. So this is what we are proposing in terms of secondary prevention of fibroid. And this is, I'm getting near the end of my talk. Then the concept of primary prevention. Primary prevention is really preventing the disease before it even starts. So individuals, young women in maybe late teens, early 20s, with a fibroid, with a uterus that doesn't have fibroid. But we know based on our research that this wall of the uterus is quite inflamed. But if we do an ultrasound, we don't see any fibroids because they have not developed yet. At the moment, again, what we do in this situation is to just wait until the fibroid develop and become very advanced, and again, intervene with major surgery like hysterectomies and other invasive procedure. Our research is heading in the direction that we can actually develop a urine screening test to find these young women in their late teens and early 20s who have a lot of inflammation in their uterus, but they still don't have visible fibroid yet. And we can identify these women based on certain markers in their urine sample. And the hope is once we identify these women that we know it's just a matter of time they will develop fibroid, we can again intervene with the same simple natural products, 5,000 international unit of vitamin D, EGCG 800 milligram per day. And actually we might be able to prevent fibroid from ever developing. This still in the research development stage, but the research is very encouraging. And I hope in the near future, I'll come back to you with more actual clinical data in humans. And that's really our approach to control this very common disease, which I consider is pandemic levels. We published our work about the concept of prevention of uterine fibroid recently. So I would encourage you to look at that if you like to have more information. And this is my last slide. I would like to thank our amazing team at the University of Chicago, our collaborators, and of course, NIH funding. And thank you so much. And I'm happy to entertain questions at the end of the session. Thank you.
Thank you, Dr. Al-Hindi. Please note that those who are tuned in live can submit questions at any time using the question and answer function through Zoom webinar, and we'll try to address as many as we can during the panel discussion portion of this symposium. Now, please welcome Tanika Gray-Valbrand, who will help us to better understand the needs of the whole person when it comes to uterine health. Welcome, Tanika.
Hi, welcome, and thank you. Thank you, Dr. Irene. I really appreciate the invitation. I'm always happy to be with SWHR and engage in these types of conversations. As Dr. Al-Hindi was giving his presentation, and Dr. Gupta, I just found it so fascinating and exciting to hear all of the advancements, to hear what will be a better situation, quite frankly, for future generations. And I'm just excited about that and happy to serve as a patient advocate, to be here today, to be amongst Dr. Gupta, Dr. Al-Hindi, and SWHR to share my personal experience. I have the task of discussing a topic of utmost significance, which is understanding the needs of the whole person when it comes on to uterine health. So the idea of all of the clinical data that we just got is important. However, the perspective from patient advocates is equally as important, I would argue. As the founder of the White Dress Project, we are an organization dedicated to raising awareness about uterine fibroids. I have witnessed firsthand the profound impact that uterine health can have on the overall well-being of individuals, and through my own personal experience with fibroids that, quite frankly, I'm still dealing with after all of these years. So just the presentations prior to mine have really resonated with me. Next slide, Gabriella, please. So this is my story. Dr. Al-Hindi just talked about teens potentially, seeing some signs of fibroids and his experience with that. And I really believe that I potentially had fibroids at a very young age. I started experiencing symptoms of frequent urination, bloating, heavy bleeding around the age of 14. And I had a DNC at 19 because doctors couldn't figure out why I was bleeding so heavily. So I guess they decided that a DNC was the way to go. And unfortunately, that did not help the issue because a DNC doesn't help with fibroid symptoms. I was diagnosed eventually with uterine fibroids in my early 20s, around the age of 25 or so. And I had my first myomectomy at 34. And during that myomectomy, 27 fibroids were removed. I've had 3 rounds of IVF. On my last round of IVF, I did get pregnant. But at 9 weeks, I did have a pregnancy loss. And now I am left with making the decision of having another myomectomy. But before that, there is my small intestine is in the way of that fibroid. So it is a much more complicated surgery to get that fibroid to potentially give me the greatest chance to be a mother. So all of that is very daunting. It's very mentally taxing. And through my experiences, I have come to understand exactly what I've been asked to talk about today, which is the critical importance of patient voices in the research and the care processes. Next slide, please. It's one of the reasons that I started the White Dress Project, because not only did I want support for myself, but I wanted to ensure that there was a community of people who understand that they did not have to suffer in silence with uterine fibroids. One of the things that impacts you so much when you have fibroids or have any reproductive health issue, quite frankly, is that you often feel alone. So I wanted to start an organization where people understood that they did not need to feel alone and that they were supported with community, and that we would advocate for better health for women who are suffering with uterine fibroids. So I'll go to the next slide. And throughout my presentation, I have a few videos that just really express why we do this work, why the patient voice is important. Gabriella, you can play the first part of this, and then we'll go to Dr. Marsh at 5:36.
My mom had fibroids. She lost a set of twins to fibroids, thought she couldn't have any children, adopted, and then miraculously got pregnant with me. When my mom spoke to me about her uterine fibroids, it made me feel that I'm not the only person, right? But at the same time, I still felt like, is this something that my mom and I are going through alone? Like, why aren't more people talking about it?
And the reason I am playing this is to show, and we can go to 5:36, Gabriella, is the importance of community and the importance of owning your own authentic story when it comes onto your health. Not only is it important for patients to own that, but we have to have the buy-in of physicians as well. You can play next.
We have to really change the script around fibroids. I've talked to so many patients over the years who just feel like, well, this is just what it means to be a woman. This is just what I have to deal with. And it's just like, no, we have a higher bar than that.
When I think about my voice, and every time I share my story, I tremble and my voice shakes. But when I think about getting through it, I think about how I've just encouraged somebody else.
Thank you. Next slide, Gabriella. So I hope that the words of Dr. Erica Marsh, which I'm assuming this audience is very, very familiar with, a great scholar, just like Dr. Alhendi and Dr. Gupta, and has done a lot of work in this space around uterine fibroids, really speaking to us changing the narrative around uterine fibroids and how, as physicians, you all interact with patients, and how, as patients, we share our stories with you. So this is just the landscape of our organization, what we're doing, how we're creating community, how many people we're impacting. And I wanted to share this not because you necessarily need to know all these stats about our organization, but I wanted to emphasize the importance of the work that we're doing and the outreach that we're having. And this outreach is not just because, we put pretty pictures on Instagram, but it's because there's a real desire. There's a real desire for people to have community, to have stories that they can resonate with, to have physicians who are willing to share on our platforms. Dr. Alhendi has been on our platform many times. He just did a webinar for us a couple of days ago. So having that physician-patient relationship that shows that we're in this together, that as a physician and as a patient, I want to hear your story and I want to hear what your experience is so that I can become a better physician. Next slide, please. Most importantly, what I want to share with this slide is what people are saying about our organization. This is just some of the work that we do, some of the experiences that we have, but it's really a community. Next slide, please. This again is just tidbits of what people think about the work that we're doing. And once again, the reason I am sharing this is to show the impact of the patient voice. And if we don't have the patient voice, then we can't influence data, we can't influence technology, because without our personal stories, a lot of that is in vain. Next slide, please. So I wanted to make sure that this quote was in my presentation because I feel like it's so important that patient voices are not just anecdotal experiences. They are essential narratives that shape our understanding of uterine health and inform the development of effective treatments and care strategies. Patients bring unique perspectives, insights, and lived experiences that can help researchers and healthcare professionals gain a comprehensive understanding of the impact of uterine health on the whole person. Uterine health is not just about a single organ or a specific medical condition. It goes far beyond that. It encompasses our physical health, our emotional and mental well-being of all individuals. And when we talk about the needs of the whole person, we really are acknowledging that uterine health is intrinsically connected to one's overall quality of life. And when we really start to think about uterine fibroids in this way and uterine health in this way, then we really begin to understand the impact on quality of life and how this can impact the whole person. I think for far too long, conversations about reproductive health have been, camouflaged in silence and not talked about, and the stigma has been there. I think Dr. Gupta mentioned that earlier. Women have been conditioned to feel uncomfortable about discussing their experiences, their pain, their concerns. But as Dr. Marsh mentioned, it's time for us to break that cycle. It's time for us to elevate the patient voice and place them at the forefront of the research and care processes, not when, the technology is over, not when we're about to launch it, not when we're only trying to get FDA approval for something, but really invoke our voices at the beginning so that you as physicians and as patients have a clear understanding of the needs of the patient community. Next slide, please. By amplifying patient voices, I believe that we empower individuals to advocate for their own needs and rights. We create spaces where patients are active participants in their healthcare journey. I won't go through all of these, but these are just some key points on the importance of the patient voice. Every time I think about, as I said in the video earlier, every time I think about sharing my story, and I didn't share it extensively today because we are on a time limit, but it's so important that I do it even though I can be fearful, or even though I hope that my message gets across, it's still so important to share it. And we often tell our community that, not everyone is going to feel comfortable sharing their story in a public setting. But however you can influence your sphere of the world, it's important to make sure that you are sharing, whether that's with your family and friends, whether that is with your coworkers, because I believe that ripple effect can drive change. It can drive research, policies, and new healthcare practices that really prioritize holistic care. A lot of what Dr. Al-Hendi talked about. I'm so glad he touched on the racism and the lack of access that is multidimensional and really is involved when we're talking about the uterine health conversation. If you go to the next slide, Gabriella, please. I thought this quote was very important from Dr. Abraham. I think we learn from medicine everywhere that it is, at its heart, a human endeavor requiring good science, but also a limitless curiosity and interest in your fellow human being. And that the physician-patient relationship is key. Everything else, or all else, follows from it. Next slide, please. I just wanted to share, as I introduced Dr. Bradley, Dr. Linda Bradley is at the Cleveland Clinic, and she's a scholar herself and a researcher and a physician. And we had a webinar that we do called Dialogue with the Doctors. And she wasn't a guest that night, but she was listening, and she had such great points in the chat. And we said, Dr. Bradley, can you come on? So I prefaced the video with that because she's at home, she's comfortable. So, she'd probably get mad at me for showing this clip, but what she says is so important. Could you share it, Gabriella?
Please know that every gynecologist is not the same. Okay, and I'm going to go on record for saying that. So I'm in a highly academic institution, as are other speakers on this call, and every doctor is not going to be the best for you, and you must be able to know the terminology as we're talking about tonight, to know what options you have, and to get the surgery with the most skilled physician and facility to offer the surgeries that many of the witnesses on this or testimonies on this call have done. And so I would say skill set, imaging, personal connection, confidence in your physician, and know that you do. Sometimes a second or third opinion is very critical. And all of us as surgeons, I'm sorry, I'm very adamant. I'm at a point in my career. Well, what am I going to say? Everybody is not the same. Okay, I don't believe that we're all the same in terms of training, interest, and expertise. And it is far easier for me to do a hysterectomy, quicker, everything else, than the skill set that's needed to do an excellent myomectomy that reconstructs the uterus to get you where you need to go, or a team of people, whether it's laparoscopic, robotic, vaginal, hysteroscopic. It's all very different. And my last point is that fibroids are unique and one of a kind, just like your thumbprint or snowflake. I'm here in Cleveland. They're not all the same. And somebody has a centimeter fibroid.
And so just in the interest of time, I just wanted to stress Dr. Bradley's point that we really, as patients, have an obligation as well to share the information with our physicians in a way that is succinct and that they can help to make the best health outcome that you want, right? So it's important to share what those health outcomes are. And I always say, I journal everything that is going on in my body. And when I get to the doctor, so that I'm not rambling, so that it's not filled with emotion, because obviously a lot of times As patients, we're so overwhelmed with diagnosis, with what's happening, with levels being low, all the things. So I write down a lot of things so that when I go to the doctor, I'm able to articulate really what is going on with me. I think to truly understand the needs of the whole person, we must embrace a patient-centered approach. Understanding the needs of the whole person requires going beyond treatment symptoms and diagnosis, and also takes a holistic approach. And I really think that it would not serve us well if we didn't mention the overall well-being and the mind and body connection. I'll play one more slide. Gabrielle, next slide, please. I wanted to, well, let me just go back to that other quote, Gabriella, thank you. We know the average American physician interrupts their patient in 14 seconds, and we can play the next slide.
We want to ensure that what we're feeling is not a figment of our imagination, especially when we go to doctors and we have a hard time getting them to hear us and to listen to us and to actually open up the conversation to hear how we are experiencing our bodies as opposed to being told what our bodies are supposed to be experiencing. So I speak to a lot of women, and the first thing that they say, I almost feel gaslighted in the industry because I'm telling you that I'm having this pain. I'm telling you that these periods are going longer and they're more uncomfortable the longer that they go. And you're telling me that it's just a matter of you getting birth control, or maybe we'll do this part of treatment, but we won't do this one. Oh, we'll do a vaginal ultrasound, but we won't do an MRI because we don't think it's that bad. We think that maybe you're putting on, right? And we have to understand that.
We can stop now, Gabriella. Thank you. And all of these videos can be found on our website and on our YouTube pages. And once again, I'm sharing these to just get a sense of what patients are experiencing. This is Tori, she's a mental health professional. And so she's speaking from her experience of what her patients are sharing with her when they come and talk about how the physician-patient interaction has been for them. Now, as I have said a lot, and I don't want anyone to feel like this is physician bashing or anything like that, but it is to show that this needs to be an improved relationship, and the onus is not only on the physician, but it's also on us as patients to make sure that we're utilizing our voices and sharing the outcomes that we want. And I think as we continue on this journey of understanding, we really need to commit, all of us need to commit ourselves to centering patient voices. I think we need to create communities where individuals feel empowered to share their experiences without fear of judgment or shame, and talk about some of those racial disparities they may feel, some of the health disparities they may feel, the dismissal they may feel, and really embrace research and care practices that speak to the whole person. And I think that can pave the way for a future where holistic uterine health is prioritized. I think together we can create a world where patient voices are not only heard, but also valued and incorporated into the fabric of healthcare. We at the White Dress Project, we are doing our part, and we always thank SWHR and other organizations and the physicians that we work with for hearing our voices and valuing us. And to conclude, I think that understanding the needs of the whole person, once we begin to really understand that mindset, then we really are taking a giant leap towards a future where reproductive health is synonymous with comprehensive well-being. Go to the next slide. And that is it. Healthcare reform is about the patient, not about the physician. So thank you so much. I appreciate everyone for listening and being here today.
Thank you, Tanika. Our final panelist Lindsay Horan will introduce how we as scientists can engage in uterine health policy solutions. Welcome, Lindsay.
Thank you so much, Irene. And Tanika, I always love hearing you speak, and I so respect how you have taken your personal story and use it to inspire people today. So as was made clear by all of the speakers in today's session, there are so many opportunities within the uterine health space to drive advancements for women's health and for their health care. We talked about addressing research and care gaps, to eliminating disparities, to considering whole person health. But ultimately, we cannot meaningfully improve outcomes unless the data that we're acquiring and the insights that we're gaining then go on to inform healthcare practices and policies. So I'm here to discuss why researchers and clinicians are some of those best suited to be messengers to inform policy, whether that's at the local, state, or federal level. And I'll end with some specific avenues through which scientists and clinicians may wish to engage in uterine health policy specifically. Next slide. So before we really dive into the presentation, I always like to take a quick step back and remind people that lobbying is a personal right that is protected by the U.S. Constitution. I know that for some, especially for those who are in academia, there's often hesitation about engaging in the policy space. The IRS has very clear definitions and thresholds when it comes to organizations participating in lobbying activities. And of course, you have to respect your organization's rules when it comes to representing a university or an organization on Capitol Hill or in the administration. But it's also important to remember that you can advocate, or what I like to think of as educate, without lobbying. So in case framing is helpful, I think of lobbying as asking policymakers to vote yes or no, up or down on a given bill, or asking for a certain level of funding for a program or agency. But simply educating policymakers on your research and how it contributes to public health is more advocacy than lobbying. Next slide. So now that we have that out of the way, I wanted to discuss the intersection between science and policy. So in 2002, the Institute of Medicine published a report on the future of the public's health in the 21st century. And that report really was revisiting a 1988 report that within it highlighted the disarray within the U.S. public health infrastructure. The 2002 report, though, through the help of an interagency agreement, was charged with looking at the public health landscape and then creating a framework for assuring population health. And within that report, the IOM committee said that the mission of public health is about fulfilling society's interests in assuring conditions in which people can be healthy. And then notably for today's discussion, they assigned the government with 3 core functions within public health practice. And those were assessing health status and health needs, assuring that necessary services are provided, and policy development. Next slide. And it's really clear, it's why the IOM committee decided to designate policy development as a core government function for public health. If we look at a report from the U.S. Centers for Disease Control and Prevention of the 10 great public health achievements of the 20th century, each of those was influenced by policy change. So those included things like vaccinations, which have resulted in the eradication of smallpox and the control of other diseases like measles and rubella, the fluoridation of drinking water, which has reduced tooth decay by 40 to 70% in children, and of tooth loss in adults by 40 to 60%. And then the recognition of tobacco use as a health hazard, and those subsequent kind of anti-smoking campaigns being successful in preventing initiation of tobacco use and cessation of use, as well as on reducing exposure to environmental tobacco smoke. So policies can make an impact. And I'll note also that they're not exclusive to the health sector. The World Health Organization has suggested that social determinants of health account for between 30 to 55% of health outcomes. So improving health and reducing inequities in health will require action by all sectors. So regardless of your focus area, your work could still play a role in improving healthcare outcomes. Next slide. And this is really where scientists and clinicians can come in. So obviously, evidence-based policymaking is the gold standard, but evidence-based policymaking also is not stagnant. It includes monitoring and evaluation on a regular basis. There is a quote that I found recently from Bertolt Brecht, which is that the aim of science is not to open the door to infinite wisdom, but it is to set a limit to infinite error. And I think that message is an important one whenever we're looking at the concept of evidence-based decision-making. There was a group called the Evidence-Based Policymaking Collaborative that said that evidence-based policymaking really has two goals, which were to use what we already know from program evaluation to make policy decisions, and then to build more knowledge about future decisions. So it's not just about having research inform the development of an initial policy and then having that be the end. We have to have regular monitoring and evaluation of that policy to determine whether what we're doing is an error, and to use those findings to create better and better policies over time and as the landscape continues to change. And truly, who better to do this than the people who are in the labs and doing analyses, or the people who are on the ground interacting with patients on a day-to-day basis. So I've outlined here just a few of the ways that scientists can help shape policy. Policymakers and their teams really, for the most part, are not reading health literature. And even if they did, that literature may not be written about in such a way that policymakers would understand it, or how to use it within their own work. Scientists really have a unique role to play in connecting those dots and how this research can inform public health practice and policy. Second, the federal budget is tight and getting tighter. We have seen a few pieces of legislation introduced in the US in the past several weeks. The House majority in April introduced a piece of legislation that would cap federal spending to fiscal year 2022 levels, which would amount to more than $130 billion in cuts. That legislation would likely impact non-defense discretionary spending, which is everything outside of defense, and notably healthcare programs and health research. It would probably affect those greatly. And then just yesterday, the House Appropriations Committee majority released a draft bill for fiscal year 2024. And it's the bill that has jurisdiction over agencies like the Department of Agriculture and the Food and Drug Administration. And within that bill, we saw funding cut to 2006 levels. So that would also be really drastic cuts. In Washington, we often use this saying that if you are not at the table, then you are on the menu. And so if policymakers don't understand how research is making a difference to them and to their constituents and within their state, it's easier for them to think that they can eliminate that funding without experiencing any real ramifications, or they may think that their constituents don't care about it. So it's really up to the members of the public and to scientists and clinicians and patients and patient advocates to be vocal about how that work is really making a difference. And then finally, science can shape sustainable policies. So, even beyond the kind of monitoring and evaluation piece that I mentioned previously, scientists also have the potential to work with policymakers and members of other sectors, depending on what the policy is, to create policies that are driven by evidence, but importantly, policies that are practical given the realities that are on the ground. Next slide, please. Unfortunately, I do recognize that there are very realistic barriers to scientific engagement in policy, or that could hinder individuals from speaking out. I've noted a few of them here, but some of the ones that I think surface more regularly are the belief that the research isn't relevant to larger policy discussions, the fear of the politicization of science, which given today's political climate is a very valid one, the concern of blurring lines between acting as a knowledge broker versus as an advocate, lack of incentive for community-related outreach. I have spoken to researchers who felt like they weren't being rewarded for anything that wasn't related to publishing or to lab work. And so anything outside of that is kind of seen as lesser value. Because that is seen as lesser value, there is little training that's often provided on science policy and communication and disseminating research to broad audiences. And then finally, there's some uncertainty about how to engage in the process. Next slide. And if you do question whether or not this is your role, I would ask you to consider these slides. The next two slides are from results from a survey that Research America, which is a nonprofit organization that's aimed at elevating the role of health research, conducted. And the results were published in January of 2023, but they asked a survey if scientists should consider it part of their job to inform the public about their research and its impact on society. 86% said yes. Within the same survey, they also asked how important is it for scientists to inform elected officials about their research and its impact on society. And 95% said very or somewhat important. So clearly, there is a belief by members of the public that science should inform policy in some capacity. Next slide, please. There is also high bipartisan support for basic research. So going back to the slide, the fear of the politicization of science, when asked, do you agree or disagree that even if it brings no immediate benefit, basic scientific research that advances frontiers and knowledge is necessary and should be supported by the federal government? 92% said strongly or somewhat agree, 92% of Democrats, and then 78% of Republicans said strongly or somewhat agree. So a majority in both of those. Next slide, please. So building off of if there is uncertainty about how to engage, I just wanted to go over a few of the ways that scientists and clinicians may wish to engage in the policymaking process. I know the one that we think of most often is we tell, reach out to your policymakers, talk to your members of Congress, your representatives, your senators, and explain what you're doing and how it makes an impact. But there are many, many ways to engage beyond that direct communication with policymakers. There is also coalition engagement and mobilizations. There are coalitions on just about everything in every issue area. And so those are groups that are likely already have their pulse on things that are happening in Washington and can readily alert you to opportunities. And you can tap into that network and that expertise to determine ways that you might be able to engage in an awareness campaign or an advocacy campaign of some sort. One outlet that I think is underutilized is the regulatory engagement space. So there is a federal law that requires that whenever agencies publish or want to change their regulations, they have to issue a public comment, an issue for public comment in the U.S. Federal Register. So things like research agencies, strategic plans, or anything related to regulation, there is the public comment period in which any member of the public, whether you're an individual or organization, can read through what those proposed changes are, and you can weigh in, providing your expertise. And they do go through all of these public comments for consideration. So that's a great way to engage in the policy process. You can keep an eye out for updates to guidelines and draft research plans from the U.S. Preventive Services Task Force and weigh in on those processes. There are also independent organizations evaluations. So groups like the Institute for Clinical and Economic Review, which provides independent evaluations on the value of medical tests and treatments and delivery systems. While that is an independent body, oftentimes their analyses inform coverage decisions that are then made by the administration. So that could be a great way to engage in the process. They also have a public comment period in which scientists might be able to engage. And then some other outlets that you may want to consider, science policy engagement at conferences. Keep an eye out for conferences where policymakers might be in attendance and arrange to meet with them there. Or just sharing outputs from science science conferences that could be impactful for policymakers or be particularly relevant for an issue that they're working on. Media engagement. So I'm thinking here, op-eds, interviews, press conferences. This venue, I think, is really best if you are working on an issue that's already kind of in the news media, so you can make a direct tie and a direct pitch to reporters and others who may already be covering the issue, but you have a unique perspective and might be able to engage in that conversation in that way. And then written publications, things like policy briefs or open access or other scientific publications. And then I'll also note that you can engage with, for those at universities, I think almost every university has a government relations department, and you could reach out to them to determine ways that you could engage either through the university or independently, but that also might provide some peace of mind to ensure that the way that you are engaging in the policy process is not conflicting with the university's rules and regulations surrounding lobbying. So those are just some of the opportunities that are available there. Next slide, please. And then finally, when thinking about ways to engage in uterine health policy specifically, these are some of the ways to do that. It's certainly not comprehensive, and my colleagues here, I'm sure, have additional insight on ways that you may want to help shape policy. But it is, again, important for scientists and clinicians to engage in these conversations, to make connections and to relay stories from interacting with patients. So there were two pieces of legislation that were that we at SWHR were advocating on last year. They have not been reintroduced in this Congress that I have seen, but the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act and the Endometriosis Care Act. Each of these would provide increased targeted funding for uterine fibroids and endometriosis respectively. There were also components surrounding having the administration conduct a broad public health education and awareness campaign, just to make sure that people were aware of these issues and so women could know what symptoms to look for. But keep an eye out for opportunities like that. Maternal health legislation may be another avenue through which you could engage. We know that women with endometriosis are at elevated risk for some adverse maternal health conditions like preeclampsia, and that fibroids can also affect pregnancies. And then I'll also flag research, so federal budget and appropriations process, and by this I mean research funding specifically. So research funding is a critical need and an area of opportunity within the advocacy space. We know that research funding for endometriosis is limited, especially compared with the disease burden. So funding from entities like the National Institutes of Health constitutes less than 1% of the 2022 health budget. And that's for a condition that affects 6.5 million women. But patient advocacy organizations and patient advocates and others can make a difference here. So in the final fiscal year 2023 spending legislation that was passed last December, there was some report language in which Congress urged the NIH to increase funding to expand basic clinical and translational research into the mechanics of endometriosis, identify early diagnostic biomarkers, and develop new treatment methods. So that was a call that Congress made specifically to the NIH, and that the NIH will now consider as they are considering future funding opportunity announcements and things like that. So that's another great venue. There's also some advocacy that can be done around the workplace. So thinking through questions like, do employers provide accommodations such as flexible work hours or the option to work from home? Do they provide a reasonable number of breaks and easy access to the restroom? Things like that that might be specific for uterine health issues, but are a good opportunity for you to advocate more at the local level. And then finally, there are just broad education and awareness needs to ensure that women and their families and their healthcare providers are aware of the symptoms of endometriosis and uterine fibroids to cut down on the time of diagnostic delay. So these are just some of the ways that you can engage. But again, I know there are many others. Next slide. And if you have any questions about how you might want to engage, or if you'd like to discuss any of this further, or if you would like to be involved in SWHR's advocacy work, I've got my email address up here, but we would love to speak with you further. If you're a patient advocate, we would love to hear your story. And thank you so much. And I will turn it back to Irene.
Thank you, Lindsay. We are running against time, so we won't necessarily have time for Q&A, but there are a lot of questions that came in and we answered them in the Q&A box. So definitely look out for that, and we can send out some information on that as well. But as we wrap up, and I invite everybody to turn their screens on, as we wrap up, I have one last question to kind of go around. We often have diverse audiences spanning patients and healthcare providers, researchers, policy professionals that tune into our webinars and symposium like this. And so we'll go around, and can each one of you share your suggestion for one solution, be it low-hanging fruit or a long-term strategy, to address a particular research gap or stigma for women living with a uterine health condition. And so we will start with Dr. Alhendi, and then Tanika, and then Dr. Junka, and then Lindsay.
I really enjoyed this session so much, and I learned so much. It's amazing. So really kind of emphasize what Tanika and others have said. I would say patient-physician relationship is very, very important. So I would really encourage patients to know their stuff, to know their disease, and don't say to the doctor, what do you recommend, or what would you do if I was your sister, or that kind of thing. Just know, because you know your body, you know your disease, you know what's important for you and your family. So the doctor should be information provider. I tell my patient, I am a technician. I need to give you options. If you decide to do surgery, I'm going to do your surgery, and so on. And I'm here to answer questions, but you need to make the decision. So I would just encourage patients to empower themselves and to know their option before so they can have an effective communication with their healthcare providers.
I completely agree with that. You are the CEO of your body. No one knows your body better than you do. So the way I look at the physicians and health practitioners in my life is that they are on my personal board of directors for my health. And together, coupled with the expertise that I have of my body, their expertise, their clinical expertise, then we can make the best decisions. And ultimately, the decisions are up to me. So it speaks to what I said in my presentation, that the patient voice is important. And to Dr. Alhendi's point, you also, as the patient, need to know your stuff so that you can amplify your voice. Thank you, SWHR.
Mm-hmm. Thank you. And I'll just make a final comment on addressing stigma as it relates to endometriosis. I think the exciting thing is that there are a lot of health conditions that are stigmatized, like I mentioned, HIV, gender-based violence, and with really rigorous public health intervention research, we have been able to reduce that stigma. So we don't have to reinvent the wheel. It's about adaptation. And I'll just say, if we can figure out how to get healthcare workers in rural DRC to screen for intimate partner violence, we can absolutely get healthcare workers here to address pelvic pain.
And my takeaway is that I would charge us all to strive for evidence-based policymaking and a two-way communication between patient advocates and clinicians and researchers, but also would charge policymakers to reach out to these populations as they are developing policy so that we can ensure that it's meeting the needs of the people who need this treatment and this care the most.
These are all wonderful takeaways and wrap-ups. Thank you so much. It's been an amazing panel. Thank you for your time, for the insight that you provided, and also to Virginia Commonwealth University for their support of this Emerging Topics in Women's Health Symposium. SWHR will continue the conversation hashtag SWHR Health Equity in our work to promote research to better understand, diagnose, and treat uterine health conditions in women. Uterine health is one of the focus areas we're adding to SWHR's Women's Health Equity Initiative. And this roadmap features U.S. data on the disproportionate impact of certain life stages in women's health conditions based on race and ethnicity, geography, age, and their role as a caregiver. So stay tuned for more information to come with that launch. We also invite you to connect with us on our website, www.swhr.org, as well as on social media to register for future events, download women's health resources, and sign up for our newsletter. We'll also be sending out an email with a recording of today's symposium to all the registrants, as well as posting this recording on the event's webpage for future viewing on SWHR's website. So please be on the lookout for that and feel free to share with others as we continue this conversation with hashtag SWHR Talks Fibroids and hashtag SWHR Talks Endometriosis. Thank you for joining us today.